Hello, my name is Elliot Huang, an internal medicine resident at Trinity Health at St. Joseph Mercy, Ann Arbor. I'll be presenting racial disparities in 30-day readmissions and utilization of palliative care in patients with CHF. I have no conflict of interest to disclose. CHF affects 6.2 million adults with a whopping annual cost estimated between $30 to $70 billion. According to the Centers for Medicare and Medicaid Services, patients admitted with CHF have a 30-day readmission rate of 22.7%, making it the most expensive measure of the hospital readmission reduction program. So CHF is expensive, but it doesn't stop there. Compared to white patients with CHF, multiple studies have shown higher readmissions and lower mortality in Black patients. A higher readmission rate in Black patients is thought to be due to various factors, including poverty, higher comorbidities, lack of health insurance, lower health literacy, use of ED as primary site of care, to name a few. Michigan has the 15th highest Black population in the U.S. To implement strategies to close a gap in health equity and deliver high-value healthcare in Michigan, it is crucial to understand the potential factors driving racial disparities seen in CHF readmissions. Therefore, we aim to characterize potential racial disparities in CHF readmissions and mortality, emphasizing key processes of care associated with CHF readmissions within the local Michigan hospitals. In keeping with the already known racial disparity in the U.S., we hypothesized that there would be a significant difference between Black and white CHF patients in Michigan. We utilized the CHF data from the Impact Registry, a Blue Cross and Blue Shield funded collaborative quality improvement initiative comprising over 20 local health systems in Michigan. Power analysis suggested that we needed 1,476 subjects to determine if a difference between the two groups existed. Our study had 4,785 patients, therefore was adequately powered. After applying the inclusion and exclusion criteria, we identified 1,776 Black patients and 3,009 white patients. Collected data included the baseline demographic of patient age, sex, insurance type, comorbidities, and other clinical variables. The primary outcome measure was a composite of the 30-day readmission rate and 30-day mortality rate. For secondary outcome measures, we analyzed racial differences for palliative care utilization, which has been recommended to be implemented early on given the significant symptom burden of CHF patients. We also looked into differences in use of guideline-directed medical therapy, whether a patient was given a follow-up appointment within 7 days of discharge, whether they were given an in-office follow-up appointment, the number of ED visits post-discharge, and LACE index for readmission. We performed descriptive and inferential analysis. Logistic regression was applied, where the binary outcome was 30-day mortality or readmission. Propensity scores were generated, and the inverse probability of treatment weighting was applied to adjust for confounding variables. Propensity scores assist in ensuring that the baseline patient characteristics between Black and white patients are balanced. There were notable differences in baseline demographic characteristics between the Black and white study population. Black patients were much younger, with an average age of 63.95 versus 75.15 in white patients. Black patients also had significantly higher rates of Medicaid as their insurance type, with 15.6% compared to 2.99% of white patients on Medicaid. Black patients had a higher 30-day readmission rate than white patients while having a lower 30-day mortality rate. However, after adjusting for demographic variables, the difference was no longer significant between Black and white subjects. Unadjusted analysis showed Black patients were less likely to receive palliative care referrals and had higher use of evidence-based medications, but this difference was not maintained after adjusting for demographic differences. This is likely from the age difference between the two groups, as younger patients would be less likely to be referred to palliative care and likely will tolerate medications better. But even after adjustment, Blacks were less likely to receive appointments within 7 days, less likely to receive in-office consultation visits during follow-up, had an increased number of ED visits post-discharge, and had a worse LACE index. In conclusion, our main results again demonstrated the paradox of a higher 30-day readmission rate and lower mortality in Black patients with CHF versus white patients. But the disparity disappeared after adjusting for demographic variables, most likely due to the difference in age and insurance types between the two groups. One possible explanation for this observation is different underlying biological processes affecting Black patients. Black patients are more likely to have early clinical heart failure, diastolic dysfunction, and non-ischemic cardiomyopathy. These features have been associated with comorbidities linked to CHF, including diabetes, hypertension, and obesity. Therefore, Black patients may suffer from earlier onset of CHF due to poor preventive care, but may respond better once they receive treatment for these underlying causes. We also found that multiple secondary outcomes vary between white and Black patients after controlling for demographic differences, which we believe is the most crucial finding, as setting up early follow-ups and seeing patients in the office are modifiable factors. Some of these process measures of CHF transition care may explain the higher CHF readmission rates in Black patients in our local Michigan hospitals. The development of a structured, tailored provision of additional support to Black CHF patients to reduce readmission rates in Michigan remains an area that needs further work in the future. Thank you for allowing me to present at the SEMCME on this important topic.